Good afternoon, everyone. We'll go ahead and get started. Welcome to Ethics for Lunch, but today is a special Ethics for Lunch. This is our annual Schallenberger Lecturer. My name is Mark Hughes. I'm a co-chair of the Hospital Ethics Committee here at Johns Hopkins. And for many of you that are familiar with Ethics for Lunch, this is co-sponsored both by the Ethics Committee and the Berman Institute of Bioethics, and today also by our Department of Spiritual Care. And let me tell you a little bit about the annual Schallenberger Lecture and Clyde Schallenberger in particular. So Reverend Schallenberger began his service at Johns Hopkins in 1963 when he arrived as director of the Johns Hopkins Hospital Chaplaincy Center. And it was a pastoral care service that for many patients would become important as the expert medical care that they would receive. During his 30 years of service, he was there for thousands of patients, supporting them at times of personal crises and helping through disease, sickness, and injury. Along the way, he also ensured that the caregivers had someone to turn to for comfort and support, and many faculty, administrators, and staff turned to him often. Reverend Schallenberger helped to establish the Ethics Committee and Consultation Service in 1985. And prior to 1985, he was active in the hospital committee that he actually initiated called the God Squad, helping patients, families, and caregivers deal with difficult ethical issues such as end of life. Reverend Schallenberger retired from the chaplaincy in 1993, but he continued as a member of the Johns Hopkins Ethics Committee. And the first Schallenberger lecture was in 1994, so this is our 30th anniversary. The annual Schallenberger Lecture is sponsored by both the Ethics Committee, as I said, and in honor of him through an endowed fund that that has had generous support of in recent years, also from the June and Yankee Family Foundation. Reverend Schallenberger died in December 2020. His wife, Helen, was also a active supporter of this annual lecture. And she also had her own connections to Johns Hopkins. She worked in the physics department, the biostatistics department, and also as the executive administrative assistant to the dean. And she died in December of 2021. Today, they're here in spirit, but we're also joined by their three children, Nancy, Karen, and Rick. I'm just going to reflect on what Reverend Schallenberger said at the end of his career. While my responsibilities have been many and varied, there is nothing more satisfying than the privilege of being available to people when they are in the midst of a life crisis and supporting them and journeying with them through that crisis. And with those sentiments in mind, I'm going to introduce Ty Crow, our Director of Spiritual Care, and he's going to say a few remarks.
Well, good afternoon, everyone. Well, as we begin and as we reflect on this important anniversary of our lectureship and the chaplain who began it, it's important to pause, I think, and to imagine also our own story. What was the practice of medicine in our hospital before ethics? Have you ever stopped to wonder what that may have looked like? Before a consultation service was formed, before even the framework for ethical decisions was published. Many of our historical healthcare institutions have had ethics codes, an appreciation for, and I think a sincere honor for the Hippocratic Oath. But medicine at the time before had long been a more paternalistic profession. Patients were expected to listen to their doctor's advice. They didn't have that many rights, and especially as they pertain to the beginnings of medical research. In the decade before Reverend Clyde Schallenberger started at Hopkins, this is the 1940s, 1950s, physicians may have opted not to share a poor prognosis with a patient for fear of creating a burden on them with that info. So the stage was beginning to take shape with a full-time chaplain, walking the halls, visiting the wards of this hospital, and the shape and the forms took time. It took consistent presence, But most importantly, it took questions. I think hard questions, the kinds of questions that can't be easily answered, questions that sparked a larger conversation, the kinds of questions that invoked a sense of spirituality, a wonder about the world, about our humanity, and our long desire to be healed, and the concerns and challenges, of course, of this desire for healing. As mentioned, these early questions and reflections included medical professionals who wondered about their own practice of medicine, integrated with their own spirituality, and how their practice of medicine was impacted, and to explore the many ways they felt disconnected or bothered in their work. So in the late 1960s, as Mark had shared, Reverend Schallenberger formed this idea of a God squad, right, that discussed such things involving real cases of care to highlight the many dilemmas that are present in our hospital. Of course, this was before even the principles of bioethics was formed and published. This was the classic from like 1979 that indicated our first sort of fourfold biomedical principles for autonomy, non-maleficence, beneficence, and justice. So I wonder what those early conversations included, which cases were discussed, maybe who was at the table even to discuss them. As an institution, Johns Hopkins clearly values medical breakthroughs, and we have a number of those, but questions were raised. What else have we forgotten? Or who have we forgotten about? Why doesn't this feel right? Or what do we need to address to move forward? So many of those remnants of early God Squad discussions became the basis of what we have and cherish today in our ethics committee here at Hopkins. It's a testament to a chaplain who was willing to engage, to invite others for conversation, and a testament to the power of faith, the desire to discuss faith in action, faith in healing, and also faith in medicine. But probably most importantly, this history shows how much curiosity about the human condition plays into every ethical exploration. I think curiosity was a driving force for Reverend Schallenberger, and he embodied this curious energy to begin to wonder and also concern for individuals, for groups, and of course, large institutions. In theology, we ask why. In theological reflections, you're guided by that beginning question. In the world of chaplaincy training, the question about why is the beginning of an exploration. Yes, the who and the what, and maybe even the how, that they're necessary, they're helpful. But when it comes to why, it opens new doors and the avenues for curious conversation. Why is this important to you? Why do we always do this in these situations? Why do you believe that intervention worked? Of course, it helps when the humans in the room can lower their defenses. No giggle. And be ready to explore rather than to explain, and to trust that something good can emerge from being challenged, something new and insightful from feeling uncomfortable. Those of us that are in the CPE training right now in the room can attest to that. The earliest inspiration, I think, for clergy training was the experience of being disconnected or some sense of discomfort. It was an unhelpful attempt at being helpful. Has anyone experienced that before? An unhelpful attempt to be helpful. It's like, anyway, in other words, a faith leader went to visit a colleague who was hospitalized. That person did care. He did show up, but he couldn't really relate to his colleague's experience, much less the feelings. And he could only recite scripture, and ultimately left him feeling unsettled. And this unsettledness fueled the need for all clergy to become more in touch with their feelings, their own stories and experiences, and to learn new ways to connect that challenge their theological ideas that were studied in books, but he needed to have the educational model transformed. So based on a human experience and certainly deeper reflection. In much the same way, our story, our movement towards connection and empathy as healers, develops through competing values, through symbols and metaphors that we try to describe what's happening, through the stories we all can relate to, and through the embrace of paradox, of irony, and even occasional wisdom. All right, so in closing, today I leave you with this invitation, allowing the work and legacy of Reverend Clyde Schallenberger to live with us here is to stay curious. Curiosity exists because you can trust yourself to go there, sometimes even using your own faith to help. Curiosity can build upon itself, especially when you surround yourself with others who are also authentically curious. We need our curiosity to help us set the tone for lowering our anxiety, helping us to create less judgment in our space, and inviting us all to speak and think more openly. Stay curious. Thank you.
Thank you, Todd. I'm Cinda Rushton. I'm the other co-chair of the Johns Hopkins Hospital Ethics Committee, Consultation Service, and faculty in the Berman Institute. And I had the privilege of knowing Clyde. I came to Hopkins in 1991. And part of Clyde's legacy was, as Ty pointed out, this curiosity. And part of how I got into bioethics was because of one of the very famous baby doe cases that was here at Johns Hopkins. And at the time that I first came here, some of the people who were involved in that case, Al Caller, were also part of our ethics committee. So this has been quite an incredible journey, lots of twists and turns along the way. And our speaker today is actually a wonderfully, oops, did I hit something? Whoops. Sorry, technology. Our speaker today, Dr. Anita Tarzian, is a really incredibly curious person as well. So she is ideally suited for this lecture for many, many reasons. She is a nurse. She joined the National Center for Ethics in Healthcare at the Veterans Administration as its Deputy Executive Director in June 2020. Prior to this, she was an ethics and research consultant here in Baltimore and an associate professor at the University of Maryland School of Nursing. She has served our state and beyond for more than 2 decades as the program coordinator for the Maryland Healthcare Ethics Committee Network, which is in many ways a real resource for all of us. It's a regional ethics membership supported initiative of the University of Maryland Law School and serves ethics committee members across our state. She is a former surgical oncology nurse, a hospice nurse, and a Peace Corps volunteer. And you'll get a sense of her orientation toward our work as soon as she begins to speak, I'm quite sure. She served on institutional review boards, and a lot of her work has focused on clinical and research ethics, palliative care, hospice, and disability rights. And one of the things that Anita did during the pandemic was really in trying to create a framework for allocation of scarce resources to really give voice to those individuals who are differently abled, so that we were able to incorporate into our framework that point of view. She has served in many roles at the American Society for Bioethics and Humanities, and notably was led the development of the core competencies for clinical ethics consultation, which was a huge undertaking, you can only imagine. She is published and presented widely and was part of the Creighton University Nursing Legacy Project. and she's also a fellow of the Hastings Center. So with that, please join me in welcoming Dr. Anita Tarzian.
Okay, thank you for that generous introduction. And I was looking at my slides last night and I was like, an ethics revolution at the VA. What was I thinking? And then I'm like, oh, wait, good job, Anita, from the past. It's evolution, not revolution. So, but my goal here is to get to that. But for those of you who count, there's 52 slides. I'm going to go fast through the first half, and that's setting us up for what we're going to talk about with what we're doing at the VA. How does that relate to people who do this work elsewhere? So the learning objectives are looking at how our ethics services have evolved. I'm going to go through the hub and spokes eventually and talk about, why should you care about that if you're not at the VA? So this is a required disclosure that the views expressed are my own, even though I'm going to be talking about the VA. The views that are personal do not necessarily reflect the position of the VA or the government. I think this is foreshadowing this picture because I was in Iceland in 2021. And if anyone's been to Iceland or seen pictures of Iceland, it's like this tiny country with beauty everywhere that is a result of a violent lava eruption. So that'll be a theme running throughout this talk, is this weird relationship between adversity and meaning making and purpose, and why are we here on this earth and what do we do with that, which I think your father, Reverend Schallenberger, would have been very interested in and spent a lot of his work thinking about it and helping people kind of figure out. So this book, I don't know if anyone's read this book. It came out in 2016. Sebastian Junger is a journalist. He co-directed the Restrepo movie, other projects. He was war correspondent. My nephew, who's an Army Ranger, suggested this book to me. Was trying to grapple with the sense that so much of our innovations come from our military industrial complex in war. And why is that? Why in this 21st century is so much of what's good about us come out of something that we would want to avoid if we could? So back in December, the Secretary of the VA, Dennis McDonough, had an author interview with Sebastian Junger. So I was excited to be in the audience over at DC VA headquarters to listen to that. And what Junger is really arguing in his book is that the PTSD that you see from combat veterans when they come back after war isn't necessarily the result of the traumas that they witness in the battlefield, although obviously that's part of it. But similar to other forms of PTSD, he's claiming that there's something about the society that that prepares people for having to go through that kind of adversity, and how they transition back into their regular life that's missing, and that's at the core of what's going on here. So the soldiers in the combat scenarios form those close bonds. That's true also in situations where the British air raids during World War II, they anticipated that people would have all kinds of psychological damage from being bombarded. The opposite was discovered, that people bonded together, the rates of suicide went down, the rates of mental illness, psychosis went down. And there's something about humans thriving in an environment where we have to rely on each other. So Junger is claiming that PTSD is a problem not just for the battlefield. Again, that there is something about our society that makes it more difficult for people to make sense of these kinds of experiences because the society doesn't have the developed infrastructure for acknowledging group loyalty, how we find belonging and purpose in each other, meaning making. We might have that in individual cultural groups or families, but the US mainstream society as a whole is lacking kind of these elements of what he would call social resilience. And he says social resilience is a better predictor of how you do after, let's say, combat trauma than and getting a successful transition back into your everyday life than your individual resilience. And so he cited these three factors that societies should have, that anthropologists have identified as improving the likelihood of a successful transition back to civilian life. One would be a cohesive or egalitarian society rather than one that's very hierarchical or alienating. So if you think about the increasing gap between the rich and the poor, and other elements of our society that kind of are distancing people from each other. If people remember the big financial failure of 2008, the fact that individual gain is prioritized over the collective good. Very few of the bankers and the traders that were at the root of that really were punished. Many of them got, rewarded basically for that. That would not be okay on a battlefield, right? So on the battlefield is where you really have the sense of camaraderie and connection based on people not having those divisions among them. So that's one. The other would be avoiding victim status. So looking at returned soldiers, combat soldiers as being should be, victimized or pitied or offered charities. He gave an example of the civil war in Sierra Leone, where there were people on one side that perpetrated horrendous crimes against people on the other side. And international aid organizations came in and they said, well, you're a victim of war, so this is expected. And instead of relying perhaps on a cultural understanding of this idea of the hot heart, that sometimes when you get overwhelmed with this hot heart, you could do things that might be unspeakable. That might have been a better way of grappling with that cognitive dissonance of what I did during war and who I am as a person. So that wasn't necessarily benefiting those veterans of that war to think of it as that they're victims. And then the third would be being a necessary or productive member of society. So this is a famous painting by Winslow Homer, The Veteran in a New Field. It's thought to be an homage to Abraham Lincoln. You can't really see, but in the lower right-hand corner, there's a knapsack, and people have identified that as a Union knapsack. So this is supposed to be a Union soldier after the Civil War returning back to the field. And there's all kinds of symbolism in here of the wheat and harvesting the wheat. Wheat was a crop that was often used in funerals that had symbolism associated with death, but also rebirth and life. The sky might evoke kind of the Grim Reaper, so coming through death, but returning and being returning to life and returning to being an active member of the society. And so again, that would be considered the high social resilience in certain cultures, like the Iroquois is one example he gives of, a warring tribe, but that it wouldn't be as much of a separation between, being at war and then coming back. People understood what that sacrifice meant. So when we think of thanking veterans for their service, that's well-intentioned, but those kind of token measures of thanking veterans, so discounts, sports event ceremonies, could serve to do the opposite. It might create a sense of alienation that reminds you that most people don't make that sacrifice, that you're in the minority. So in countries, for example, where they have mandatory military service, or people understand that sacrifice, it wouldn't make much sense to like thanking people for their taxes. I had to work in a tax reference since it's taxed yesterday. I got the death covered because we're talking about ethics, and you can't talk about ethics without end of life. So this idea that, again, there needs to be this collective shared public understanding of the meaning of war that is defending the collective. And that, this is something that's been a thread through the history, is this two things that they've noted in early human evolution is an altruistic defense of the group and food sharing as a way that people bond. So we see that in the aftermath of 9/11, and I have to thank my former colleague, she's retired since then, Barbara Chanko. This is her photo. She gave me permission to use it, taken from her window. It was particularly poignant for the center because Bill Nelson was working at the time for the center, and his wife died in one of the Twin Towers. And after 9/11, the symptoms of PTSD among veterans dropped significantly. There was fewer suicides. This wasn't just true for veterans. There were, I didn't fact check this, but what I read was that there were no mass shootings for 2 years after 9/11. how do we make sense out of that? That there's something that people are reminded that to bond together. Again, I know that's an oversimplification because there are Muslims that didn't feel as included, but even people stepped up to acknowledge that they're members of society. We have to be speaking as one voice. And so, this idea that that kind of a connection in society is what we crave, but that isn't there consistently in the society that we currently have. And what's behind that? Well, we know that, technology is great, but that it's also distanced people, created disconnections. Some of us had breakfast earlier, we were talking about, before its current methods of communication, it would take a while for information to travel, that you would, it would take weeks or months, and people would have the opportunity to adapt and, create new rituals to keep up with the times. Well, now you get things instantaneously that are globally transmitted, which is wonderful because, we can communicate more rapidly, but there's vulnerabilities there. And I don't know if people have heard of the term brain hacking. That's what the social media software engineers came up with as a way of describing ways that you exploit the human brain. And we know that we've evolved these ways, these shortcuts that happen kind of subconsciously and dictate our behavior, and that you can manipulate that through bots and social media that are not even, people that are pretending to tweet that aren't really tweeting, or whatever they call Twitter now. So that is, a challenge for us. I think they say 80% in the US live in urban centers, and there's advantages to urban centers because we get to mix and get exposed to new ideas, but we're more disconnected from the source of our food, from how infrastructure is repaired, all of the gas, oil production, farming, people are disconnected from that. Not everyone, but for the most part. So there are also racial and ethnic divides. We talked about the income gap, the increasing income gap, increase in rampage shootings. So that can, I think, seem kind of overwhelming. Well, what do we do about that? And Younger said that, again, these divisions are avoided in the platoon, which is a part explanation for why many veterans come back and feel like, while they're willing to die for their country, they're not necessarily aware of how to live for their country. And he had a powerful quote here that says, whatever the technological advances of modern society, the individualized lifestyles they spawn seem to be deeply brutalizing to the human spirit. So how does that relate to healthcare ethics? Well, I think that, there's a lot of battle metaphors in medicine. It's not the same as being on an actual battlefield, but there's a lot that's in common, right? We see that in the language we use. You're on the front lines, you're in the trenches, you're battling with a disease. We refer to healthcare professionals, especially during the pandemic, as heroes. So I think, while people are trying to get rid of some of these terms to project more of a humanistic medicine, I think it's inevitable that when you're confronting death and illness and despair and suffering together, whether that's in battle or in a healthcare setting, there is, a need to kind of figure out why are we here? What is the purpose of all this? How do we make meaning of this? And how do we bond together to support each other? So a lot of that, again, has to do with how we set people up to make sense of that kind of sacrifice, whether it's a healthcare provider or a soldier. We saw this in the pandemic, the banging of the pots, through these acts of solidarity. I don't know, people saw the different homages to the Key Bridge, the Minneapolis I-35 West Bridge. They lit up in the colors of the Maryland flag as an act of solidarity. We see that, we respond to that. I think people send their Instagram or their tweets to share in that at some level, but that's not quite the same as having it embedded within the different milestones over the lifespan in a kind of more holistic way throughout society. So, how do we reclaim that? What do we do about that? Well, I remember once going, this was years ago, I went to a presentation about end-of-life care in an ICU setting. And I don't remember the particulars, but I remember asking a question at the end. I said, since more people are dying in an ICU, don't you think there's an obligation among the healthcare professionals to create new rituals to help people through these transitions? There's new experiences of dying in that kind of environment that people haven't had the time to culturally adapt to. And it would be our duty to try and help them through that. And the speaker at the time said, no, I don't think so. People historically have adapted, they evolve, cultures evolve, and just let people do their thing, which I thought was naive. I think that people need help in figuring out, how to make it through life's milestones and all these existential hurdles. And we can help them, and we should help them. So how do we do that? Well, Junger had one idea he came up with. This is like mindful reclaiming of what kind of we've lost in this fast-paced change. And one of his ideas was vets town halls. You can go and look at the link later if you're interested, which is just having vet centers on Veterans Day open their doors to not just veterans, but members of the community to hear stories from veterans themselves. What was their experience like? They don't often talk about it because they don't have that sense of the community welcoming that and really wanting to understand that in a meaningful way. This is a very well-known article that was written a long time ago, back in the 90s, Margaret Urban Walker, who framed ethics consulting work as a way of keeping moral spaces open. So I think, healthcare ethicists, the ethics consultants, sometimes are practical. They should be. If somebody has a direct question, I'll talk about this in a couple slides coming. You can answer them, and you don't have to have a reflective time. We don't need to think about the meaning. And so that's one way of helping direct ethics knowledge transfer. But oftentimes, as was alluded to earlier in the comments, you're doing more than that. You're coming with that sense of curiosity. You're listening to these different perspectives. I have a friend who thinks graphically. She thinks in pictures, so she's always converting words to pictures. So I've always changed my terminology now from, I used to say big picture. And I was trying to explain what an ethics council is like, and the family and the team were in conflict and they couldn't agree on what to do. And I had to encourage them to zoom out, let's zoom out. What are we really talking about here? And when I said zoom out, she really responded. She said, oh, every time you said big picture, I was trying to picture a big picture and I couldn't picture it. So even when we think we're being really clear, and you've heard that before, like I've told them over and over again, and they're just not getting it. That sense of curiosity and asking the question and like, what is it that I don't understand? What can I learn from you? Is part of what you do when you do this healthcare ethics work. Shining a light on an issue that, people might not want to think that deeply about, just carving out that moral space for people to kind of take a breath and, shift their frame. So I think anytime you're doing healthcare, you're doing ethics. It's embedded in the nature of the work. So that gets a little tricky for us because at our national center, we talk about staying in our healthcare ethics lane. When you say ethics at the VA, people think a lot of times government ethics. So I often will frame it as healthcare ethics. But, it's hard. It's hard to separate. Where do you separate clinical care from that ethics care? And I'm going to talk more about that in a second. But, I think we do this in medicine. We certainly do this in ethics. If this is an honor walk that's honoring organ transplant patients who and their families after their organs have been procured, there are all kinds of examples that I'm sure many in the room could give. And hopefully I should have said this at the beginning. At the end, rather than question and answer, if people have a story or an insight, you don't have to ask a question. I would love for people to feel welcome to share any kind of, thoughts or insights they have at the end. No pressure, but just if you feel inspired. So I think that there is this overlap in healthcare provision and then healthcare ethics consultation work of preserving this opportunity to reflect more deeply on what is it. You're not just taking the patient apart and dealing with the parts. We're looking at the whole, and we're looking at the whole within the context of their lives and the people they love and what's most important to them. So, okay, so the plan here is I'm just going to talk about a bit background on the VA because maybe people aren't as familiar with where the VA, how it originated. So we're going to go a few slides on that, a few slides on our National Center for Ethics in Healthcare. And I think, you know, the VA is an interesting place. It's been referred to as this. It's not a podcast from us, but this was one that talks about some of the VA's innovations. This is Dr. Zev Newworth. He's in his 7th year of this podcast on exploring ways to improve healthcare in the U.S. And he interviews here one of the VA leaders who has Dr. Zanetti, who has served. He's a family practice, public health background, and an informatics person, so cross-trained, and has done a lot of collaborative work with Medicare, CMS, and billing, and ways that we can take ideas that have been maybe piloted or tested in the VA because of the size of the VA and the resources at hand, and then exported into beyond the VA. So this idea of a test kitchen is sort of the spirit here. As there are things that you might hear about the VA that could be relevant for how you're thinking about how you would think about healthcare ethics works. All right. So I think this is particularly poignant for me to be talking now when we look at how divided our country appears to be. I think people can agree that this is not an ideal scenario, and this is not the kind of social resilience that Junger would think is positioning us well for success. This idea that you're pointing the finger, not us, but you know, the collective at the other side is dangerous to democracy. But if we think about go back in time to 1865, end of the Civil War, when Lincoln was delivering his 2nd inaugural address, and he really planted the seeds for the Veterans Administration. He in his speech said, "With malice toward none, with charity for all, with firmness in the right as God gives us to see the light, let us strive on to finish the work we are in, to bind up the nation's wounds, to care for him who shall have borne the battle." And that was carried over into VA's mission statement, which changed last year, and more on that later. But this was the plaque on all the VAs. So Lincoln signed into law this establishing national homes for disabled volunteer soldiers. Later in 1930, President Hoover created the Veterans Administration in order to consolidate and coordinate government activities affecting war veterans. 1946, the Department of Medicine and Surgery was established within the VA, and there were other programs that really were enabling the recruiting and retaining of top medical personnel for the VA. So it was an idea of taking care of veterans, but also serving as a kind of center for excellence. President Reagan elevated the VA to a cabinet-level executive department in 1989. This is the Department of Veterans Affairs. And the Department of Medicine and Surgery became the Veterans Health Services and Research Administration, which is now the Veterans Health Administration. And even within our own center, I sometimes, when I'm kind of referring to something, I'm like, do I say VHA or VA? Because it's a VHA program, but it's supported by the VA. So VHA is where I'm situated at the National Center, but we provide resources for VA, Big VA. So Big VA has 3 arms. The Veterans Benefits Administration is responsible for distributing about $135 billion annually in benefits. That's a lot. To about 6 million veterans and family members. This includes disability compensation, pensions, education and training, home loans, insurance, et cetera. There's the National Cemetery Administration, which oversees the burial grounds that were the national homes for disabled volunteer soldiers. That there's 103 national cemeteries, and about 15% of all eligible service members are buried in one of the NCA cemeteries. There are other cemeteries as well that are referred to as soldiers' lots affiliated with those residences. Then there's the VHA. So VHA is the largest integrated healthcare system in the US. When they say we don't have socialized medicine in the US, that's wrong in this aspect. We do have that in the form of the VHA. About 172 medical centers around the country that are adapted from, they were basically private hospitals and hotels that were leased by the Public Health Service and the then Bureau of War and Risk Insurance to be designated as those early soldiers' homes and then evolved into medical centers. So we have about 9 million enrollees, and a strange fact is that about 6.7 of them actually receive care within a given year. So there's more that are enrolled than actually go to a VA facility in a given year. This 50% number has gone up. Used to be, I think, about 25%, but because of expansions in service and because there are fewer veterans than there used to be, it's of all the veterans, about half are receiving some form of healthcare through the VHA. Research, they have a really substantial budget for research. And this is, I'm not going to read all that, but you can see that there are lots of different outcomes of the congressional appropriations for research. Just to give an example, one of the ORD's strategic priorities is increasing veterans' access to high-quality clinical trials. And VA's CONFIRM trial, which is expected to provide definitive guidance on the best methods for colorectal cancer screening to prevent death, completed enrollment of 50,000 veterans in late 2017. That made it the largest single trial in VA history. And I'm on a work group for psychedelic-assisted therapy, which is expected to be approved. Those are psilocybin and MDMA and all of those agents that are together combined with a protocol that allows people to overcome things like addiction, PTSD, if they're approached in a systematic way with support and integration after the experience. So, that's going to be a huge research endeavor because you start with research in the VA. We don't have any funding for that yet. That's VA funding, but that will change. So, also, what people might not be aware of is the VA Office of Academic Affiliations, which coordinates a massive training effort. About 2/3 of our nation's practicing physicians and allied health professionals, I was one of them. I did my first clinical rotation at Hines VA in Illinois. About 2/3 have trained at some point in their career at a VA facility. So another thing to be aware of is that VA is a beneficiary program. So people have earned the right to their VA services. They don't get it automatically. You have to qualify. And so this results in veterans who are getting VA care under VHA are sicker than those who don't. So they have more chronic physical and mental health conditions. This is related to their eligibility criteria. So that's based on length of military service, presence of a health condition that's related to military service, and income. And you can see all of those disorders that are service-connected disorders that would be factored into your eligibility. And then the eligible veterans are sorted into VHA enrollment priority groups that determines how much they contribute. So some of them are 100% service-connected, some of them less so. And then again, since 1980, that eligibility has expanded to cover more veterans, with the greatest expansion since 1980 coming with the PACT Act that was just passed not too long ago that provides care for veterans with toxic exposure during their service. You can see here in the slide, the light blue is the veteran and the darker blue is non-veteran. This is prevalence of diagnosed health conditions. So again, we have a sicker population of enrollees overall. So we consider this to be not only a beneficiary service, but a safety net for some of our most vulnerable citizens. Okay, and then we have, this is not all inclusive, but there's a whole slew of wraparound services available within the VA. So we have, I won't list them all, but there's I think that situates the EHA enrollee differently from someone who's coming into Hopkins. And again, we were talking earlier about, the dilemmas that come when you have somebody who's in the hospital, but you don't have options for them post-discharge. Well, there are more options for someone in a VHA services than there might be in the community, although they can also access community services. So now to our center. So our center was founded in 1991. There's a field-based national program office that was situated in New York. We had offices in New York and Washington State, moved to the central office in DC in 1999. And our staff on our center have different disciplinary backgrounds. So we are multidisciplinary collective expertise. You can't see all these pictures, but this is our current staff. My executive director, Toby Schoenfeld, and recently hired director of research, innovation, and data ethics, which spells RIDE. So we have a new acronym. Jake Earl go in person to our DC office, and then other staff work remotely around the country. So this is our hub and spoke model, and I have to explain how this works. So this is like clinical care. So if you're a hospitalist in the hospital, the VA or outside, you might have somebody come in and you're monitoring their cardiac, EKG, because they have maybe some blood electrolytes that are off. You're doing cardiac care, but you aren't considered to be a cardiac consultant because you're doing the primary level of cardiac care. If they have a more complicated cardiac situation going on, they might call a cardiology consult. That would be considered a secondary consultant, is the specialist that they would call in. And then sometimes even the consultant gets something that's unique and particularly rare. They might call in another more specialized electrophysiologist or someone that would be tertiary consultation. So we've adopted that language, and not with each other. We don't call people secondary and tertiary, but when we're talking about what we do, we provide tertiary ethics consults to the facility ethics consultants who are doing the secondary consultation. So they're the designated ethics consultants in the facility. So as I mentioned earlier, that medicine is inherently a moral endeavor. There's ethical issues and questions and uncertainties that are embedded in healthcare delivery. Healthcare providers are engaged in shared decision-making with patients. This often has to involve, what are the core values at stake? And, core values align with ethical duties, avoiding harm, promoting good, treating people with respect, being fair. So healthcare providers have to have this basic knowledge of ethics. But there comes a time, like with other clinical specialties, where the body of knowledge and skills that you have to be proficient and to actually be of help to people that have ethics questions surpasses what the basic clinician would reasonably be expected to know or understand. It's like palliative care. When I did hospice, I was like, I wish everybody had the knowledge to provide palliative care because it spans over all the disciplines. And end of life care, same thing. But there's just too much that we've learned to know to expect generalists to be proficient. So we have this service, and here's where I should have done a big stamp on the slide of gross oversimplification impending. So this is a really rudimentary way of lumping and splitting. So let's just play with me for a second. If you were to separate the kinds of questions that come up, there's two general ways that an ethics consultant, healthcare ethics consultant might help. One is what I would call direct ethics knowledge transfer. So that's if somebody just has a question, an ethics question, but there's a specific designated answer to the question, and it's pretty straightforward. The other is basically everything else. So let's give an example of this. Okay, so let's say that let's say that you're in the VA in Baltimore, okay, and you have a patient who lacks the ability to make any kind of decisions. So let's say they're unconscious, and the patient has appointed a healthcare agent, and they also have an appointed guardian that was appointed through the court. And they call the ethics consultant and they say, hey, who is the legally authorized representative here? Is it the guardian or is it the healthcare agent? Well, if you're in University of Maryland and you get that question, it's the guardian, because that's the way the Healthcare Decisions Act ranks surrogates. If you haven't appointed, if you have appointed healthcare agent, they put the guardian first, because guardians have obligations to report back to the court, and there's other reasons for that. In the VA, it's the opposite. So if you're at the VA, the answer to that question would be the healthcare agent trumps the guardian, although it's prudential to keep them in dialogue, right? You can still advise the healthcare agent to keep in communication with the guardian because they have obligations based on their duties. And so hopefully the ethics consultant would also explain the ethics rationale for that. And that would be that, the veteran made a point of, or the patient made a point of appointing their healthcare agent. They're the person they wanted making decisions for them. And so we would think that, that's our gold standard, is basing treatment decisions on what the person actually would have wanted if we have any way of knowing. And usually that's not the case with the guardian. The guardian is appointed by the court. They often don't really know the patient very well. And so that's an ethics question, because it has to do with what's doing the right thing for this patient, but it's pretty straightforward, right? All right, so let's think of another example. So in example 2, this is the other category, right? So what if you have a social worker, let's say, who's taking care of they're taking care of a patient in the ICU, and they realize that the patient's life-sustaining treatment orders, so in the VA, they have an LST plan, life-sustaining treatment plan, and then a set of medical orders. It's sort of like the MOLST in Maryland, is contradicting what's in the patient's advance directive. Okay, so this is the VA advance directive, and I don't know if people can read that, but it's like, think about each situation and, initial your preference. So if you look at like the bottom one that's highlighted, it says, if I have a condition that will make me die very soon, even with life-sustaining treatments, what would you want? I would want life-sustaining treatments. So that makes it, that seems like, okay, pretty clear what the person wanted. But is that a simple question? Is that like, that's one where you kind of need to gather more information, especially in the VA? We have the Life-Sustaining Treatment Decisions Initiative. There's all kinds of resources that are available. We have an approach to advanced care planning that doesn't just focus on the advanced directive, which is a legal document that can either be the living will, where you go through those kinds of preference checklists, or appointing a healthcare agent through the durable power of attorney for healthcare portion of the advanced directive. So we consider all of those as part of the umbrella of advanced care planning. So you'd want to ask, what's going on here? Is the veteran truly unconscious? Does the veteran have any capacity? We know that capacity is situation specific. Somebody can have the decision-making capacity to appoint a surrogate, but not have the capacity to fill out a more complex document because it requires less cognitive load to say, oh, I want my son to make decisions for me, and so those are all kinds of things that would, you want to get to the asking of the question, be curious. You want to check the thinking. Sometimes there's a story from the book, The Undoing Project by Michael Lewis, where he tells the story of a trauma center in Canada, Toronto. I think it used to be a World War II VA hospital or something. But anyway, it's a trauma center now. And this Don Riddlemeyer, I think was his name, was employed as a person who would check the trauma staff's thinking when they were making determinations about the patient's prognosis. So they give an example of the patient that came in with a motor vehicle accident, had a lot of bones broken in her body, and then started having really irregular heart rate rhythms. And so they heard her say something about hyperthyroidism, and that could be a common cause of this kind of heart rhythm change. So they're like, oh, it's the thyroid. So they're going to start treating her for the thyroid. And Don Riddlemeyer comes down and says, That is something that causes heart rhythm disturbances like this, but is it the most probabilistic? Is it the highest probability cause? Let's think of other things that would be more likely in this scenario. And they, had done a chest X-ray, but the chest X-ray didn't show that she had fractured her lungs, and so it was really a different cause. So that's an example in clinical care of having somebody just sort of check your thinking, because we know that we are prone to making these kind of mental shortcuts, and we have different forms of bias that can affect our thinking. So there are all different ways that ethics consultant can serve in that other kind of example of not just answering a direct question through knowledge transfer, but maybe asking more questions, getting people together. Maybe there's, disagreements among people that are involved. So in that sense, our hub is ideally situated because we have, this vast enterprise of VA facilities. And so all of them can access the same resources from our center's hub. So if you're in a healthcare system, it would make sense to have somebody looking across the enterprise and saying, this is coming up a lot. Let's throw up a frequently asked question to this. Let's do a training on this. Let's, put something up on the the online learning platform, a presentation. And that takes care of a lot of the knowledge transfer kind of challenges with staff that might not have that deep dive of ethics knowledge. But there's a problem, there's a challenge here. And the challenge comes with, how do you get people who are proficient when you need an advanced level practitioner? So you can imagine, and I think the people who have done ethics consults can come up with scenarios where things have gone the wrong way because people are just not experienced enough in the role to know the kinds of questions to ask, or they draw premature conclusions about what's going on. So one is that you need enough, especially complex consults, to be proficient. This is what I would call the chicken egg phenomenon. So in order to do this well, sort of like the Malcolm Gladwell, you need to do things 10,000 times. Well, maybe not 10,000, but you need enough consults to get good at it. But once you're proficient, people call you more, right? And then that's the second phenomenon, which is what I will call the field of dreams phenomenon. If you build it, they will come. If you get really good at this and people can trust that and you have the discernment and the wisdom to know, if I'm asking you a direct question that I want an answer, I want you to have the answer. And I don't want to overcomplicate it with a lengthy process that when it doesn't need to be. But I'll get to another caveat on that one in a second. The problem there, though, is that once you get proficient and the consult volume increases, that's difficult to maintain workload if you don't have dedicated time. So in our center, we don't have the authority over facility directors to hire a full-time ethicist. We made a pitch for that. It wasn't budgeted, so it's up to the individual facilities whether they're going to do that. We support that. We provide resources to support that. There are some out there that do that. But for the most part, they're like elsewhere in the country. They're people who have other jobs that are doing this as collateral duty. And that can lead to, burnout and work overload and a disincentive to increase the volume consult by promoting the service because they're busy people that are doing other things. So that's the vicious cycle of if you're not doing a lot, you don't get good at it. If you get good at it, you get more of it. And then you're, kind of in that situation. This is just a high reliability organization slide that I put in here because VA is promoting this. A concept of high reliability organizations is what this is called tight, loose, tight approach. So we establish the standards. That's the tight step, our center. Then the loose part is you don't micromanage people. You let them figure out what works for their own setting. But then you're tight at the end again with evaluating whether it's working, evaluating. Do we have consultants designated at the facilities like they're supposed to be? Are they competent? Are they documenting in a way that meets standards? So this is another slide that requires some explanation because I'm going fast and furious with my haphazard numbers that I'm throwing out. And I might confuse you with my 80-20 rule. First of all, this is not the 80-20 Pareto principle that Italian economist came up with. That's like, what is it? 20% of the effort produces 80% of the outcome. Like, that's a concept that, fewer people produce the most outcomes of work outcome. So this is a different form of 80-20. So we came up with this 80-20 where we would consider that 80% of the consults that come in should be handled by the facility ethics consultants. And 20% are the most complex for us complex. So understanding that if you're new to the role and haven't yet been fully trained, even the most simple thing that comes to you might seem complex because you're not trained yet. So we're defining complex as what we would consider to be complex. So that again, this is the functioning of the hub, that you empower people out in the field to take care of most of the consults. And then we serve as either peer support for those that are doing complex consults. They want to have that other check on their thinking. They might be, wanting support though from newer consultants. So either, the proficient consultants that want their peers to kind of help them, or they're newer and they want kind of more coaching and mentoring. So this is the caveat when I said that there were two types of, I was overgeneralizing. If we have two different categories, direct answer to a question, everything else, there's a third category, which is where something comes in as a simple question that they just want a simple answer to, and it's in disguise. It's a question in disguise. So an example of that would be, somebody says, hey, I got this patient who can't make any decisions and needs a surrogate to make medical decisions. Can the close friend serve as the surrogate? So VA, like Maryland, has a provision. Maryland's Healthcare Decisions Act VA policy allows for a close friend, if they sign something saying that they know the patient's values, they can serve as a surrogate. But what if that consultant asks a few more questions and they come up with, they say, oh, well, the veteran was deemed to lack all decision-making capacity, even though he's up and walking and talking because he has dementia. And so you're like, wait a minute. So this is where your curiosity comes in and you want to ask more questions. You could answer that simple question and just say, yes, here's the provision. This is what you do. But you want to be able to be sure that you're eliciting the correct ethics question or concern that's occurring with that scenario. So just a reminder of decision-making capacity is situation specific. As I said before, you have to be able to communicate a choice, understand what you need to understand, reason, and appreciate the pros and cons of the choice. So like in that scenario, like let's say it turns out that the patient was delirious from being in the ICU and they treated the delirium. And now there's been some, even though before it was considered the patient lacked global capacity, now the patient can make some decisions. So is it really fair that the patient is designated as not being able to make any healthcare decisions? So that would be a situation where you would want the ethics consultant will want to ask more questions. And this is where we get into this, the difficulty of really establishing a consult service with people who are proficient enough to know how to triage the consult requests, to know if you've got that third kind. And if they're the first kind, it works out really well with our hub and spokes because we have a lot of resources collectively that they can access. But if it's, the more complex consults, I think it works well because we can help them through their consulting with us. The question that arises is whether that 80% of cases that are being handled by those facility ethics consultants are really, they're getting the request for consult that we think the demand is actually there. Sometimes there's actual ethics problems going on or questions that arise, but this never gets to the ethics consultation service because people either don't know it exists or they don't call for help. I've had people call me, not from VA, but outside, just friends who are clinicians, and they'll say, hey, can I run this case by you? I'm trying to figure out what's the right thing to do. And I'll say, well, don't you have a consult service at your facility? I'll never call them. They don't know what they're doing. So that's the problem when you have in name a consult service, but the providers who are busy people juggling a lot don't really have the confidence or trust that the people have the deep dive knowledge and skills that they need. So this is only 4 or 5 slides left, so we're almost done to get your comments ready and stories. No pressure, family. This is our current approach to healthcare ethics at the VA is really focusing on growing healthcare ethics communities and healthcare ethics expertise. So we have recently reorganized into 4 geographic regions, and we have designated staff that serve those regions. So it could be kind of in the past, I think a little maybe intimidating to call headquarters for a consult. Now it's calling Megan or Bob or Robert or all of our other wonderful consultants that they regularly interact with. So we're also moving away from healthcare ethics committees because there's been, I think, not just in VA, but some question about whether that's the most efficient way of getting ethics out into the whole organization. It tends to be that, not everywhere, but it tends to be that people who are interested in ethics join the committee. They meet once a month, they have a lunch, they talk about cases, and then they don't really do much in between those meetings. So this idea that we'll have a healthcare ethics chief ethics consultant who will oversee their facility's ethics consultation service, and they'll serve as the group that provides the healthcare ethics services. And then they will partner with others at the facility who are the ethics experts. So some of the challenges, I'm going to go a little quick so we have time. We end in a few minutes, right? Request a bypass if we get people that call us and they don't go to their local consult service. There's a challenge there because we're trying to empower the local consult service, but we also want to be of service. And sometimes there's situations where it might be wise to allow the staff person to contact us directly. But for the most part, we want to empower and coach and mentor the local ethicists. So we usually refer to that first. The other would be how to trust the information you're getting. So we're getting information through the facility ethics consultants. So they're telling us what the medical facts are. They're telling us what the involved parties have said. Sometimes you question what the actual facts are. And then addressing gaps. So this is just real quick, 3 different competency pathways we've developed. One would be formal education with ethics consult experience. The other would be a portfolio if they are in the VA system that they assemble. And the other is a certificate that's available through the national organization. We have a regular ethics consult course and a chief ethics consult orientation that's very practical for how you run a service. I'm assuming these slides will be available, so I'll let people look through that. And then just in closing, there's a couple of other national initiatives at the VA. This is a decision-making that's not ethics consultation with facilities that goes across the enterprise. One is a decision-making capacity assessment template for the electronic health record that helps clinicians document and assess capacity for reasons I kind of alluded to earlier. We're working on an artificial intelligence ethics assessment training for people to be able to appraise whether AI-enabled products meet ethics standards. Same for data. There's ethics principles governing data ethics use. We're doing more research ethics consults. So there's a lot of other things that we're doing across the board. But I want to close with I think it's poignant also that the mission for the VA changed last year. If you see the original mission, it excludes women and people who have not veterans who have not served in combat positions and families. And so in a nod toward the future and our constant need to evolve, this is the new mission to fulfill President Lincoln's promise to care for those who have served in our nation's military and for their families, caregivers, and survivors. And I just want to close and thank you for your time and thank the family for allowing me to be here and honor your father in this way. Thank you for your attention. All right.
Comments, questions?
Somebody tell a
insights?
story. Somebody tell a story.
All right.
Mm.
As a veteran, I'm very glad to see that they've changed that because the fact that we have been serving the military and I just want to say thank you to changing that. I'm
Thanks.
very glad for the sessions.
Mm-hmm.
It's nice to see finally VAs.
Right. Thank you. I agree.
Thought, questions, comments? Mark?
One question would be, do ethics consultants need to stay in their lane? So a lot of the ethics committee members who serve as consultants have their own discipline. They might be a nurse or physician. And so when they receive a question, from a clinician, they're stuck with a case. Can they answer it from their discipline perspective, or should they only answer it as the ethics consultant?
Right. I think it's really important to keep the hat of the ethics consultant on when you're serving in that role, but you can't divorce who you are. So sometimes if you're the clinician and an ethics consultant and you recognize that, wait, this clinically doesn't make sense to me. One way of handling that could be, I'm stepping out of my role. You could just say that out loud. Right now, I have a question that's coming from my medical background. So I do think that it's important to stay in the lane of when I'm doing ethics consultation, you want to make ethics recommendations. And I've seen that in sometimes write-ups where people will say, pull the tube. The recommendation is pull the feeding tube. That's a clinical recommendation, not an ethics recommendation. And that is a common error that I think well-intentioned people have. They function from their primary role. So if they're the chaplain, they might be doing chaplaincy, which is, not wrong in itself, but you want to make sure that people are clear on what your actual role is and how you're functioning. Thank you for that.
As the ethics consultant to, you said 4 different regions around the country. That person is on call for X number of facilities and they did handle that kind of volume and then reports back to the person at that facility that's responding to the ethic. Can you walk us through this maybe one more time?
Right. It's basically the facility ethics consultants are responsible for providing that coverage. So we require them to triage calls within a certain time frame on business days and then have an after hours capacity. So when they need us, then they would call us in for that tertiary consult. So this is what's probably talked about in the future is whether our center will ever do teleethics at that facility level. There's reasons why we're not doing that now because we're not there on the ground. But we've done that with other telemedicine efforts at the VA. So we talked about that, but it has implications and repercussions that would have to be addressed. So right now they're always calling us at the tertiary level, but the facility is the one that's going to be covering, they're doing the primary consults. That makes sense. Alan.
So, thank you, Anita,
Okay.
for giving us a different sort of frame on the possibilities of integrating ethics work across our system. we have had years of conversation about how to do that, how to spread the wealth, and also how to provide more service. So this has been an interesting model for us to think about. And I want to thank our wonderful Schallenberger family for making it possible for us to gather today and to again remember Clyde and his incredible contributions here at Johns Hopkins Hospital. And thank you all for coming, and we look forward to seeing you at Ethics for Lunch next month. Thank you all very much.